morning, everyone, and welcome to the How to Prevent the Spread of Measles in Children's Camp webinar. Today's event will be 1 hour in length and will include time for questions and answers. We will have two presenters, Dr. Elizabeth Rausch-Fung, the Director of the State Health Department's Bureau of Immunization, and Tim Shea, the Assistant Bureau Director for the Bureau of Community Environmental Health and Food Protection. Additionally, we are joined by various experts in both infectious disease and environmental health to assist in answering any questions that may arise during today's event. Viewers may submit questions at any time by using the chat function at the lower right-hand corner of your screen. Please make sure you send all questions to either all chat or to the panelists so we can see them. Questions will be answered at the end of the presentation. Today's webinar is being recorded and a link will be made available following the completion of this event. Now I'd like to turn it over to Dr. Rausch-Fung, who will begin with Measles 101.
Okay, one moment. We're just arranging the slide. One moment. We just have a slight technical difficulty, and then we'll proceed. Okay, we apologize for that delay, and for anyone joining us, you should be logged in via the webinar and seeing slides now, as well as dialed in for the phone. I suppose if you're not dialed in, you can't hear that, but you can put those instructions verbally. If you're having difficulty logging into the webinar, then please consult the instructions from when you registered. Okay, so as announced, I'm Dr. Betsy Rausch-Fung from the State Health Department Bureau of Immunization, and I'm going to start out today's webinar with a brief overview on measles disease, where it's spreading, what it looks like, and what to do if you have someone in your camp who you think might have measles. This is a map of cases of measles associated with the current outbreak in New York State outside of New York City since October as of last week. And you can see there's been a large outbreak in Rockland County, as well as additional outbreaks in Westchester, Orange, and Sullivan County. And not displayed here on this map, another very large outbreak in New York City, which is currently reporting, I believe, 588 cases of measles, predominantly in Brooklyn and Queens. Measles is also in other locations as well, outside of New York State. Several other states have had small outbreaks this year and late last year. There's also many outbreaks of measles in the world, in other countries, in Europe, South America, Asia, including two very large outbreaks going on for quite some time now in Israel and the Ukraine. So it's very important to be on alert for cases of measles coming from Rockland, Orange, Sullivan County, Brooklyn, or Queens, but also be aware that unvaccinated campers and staff coming from other states or other countries, or those that have recently visited other countries, could bring measles into New York State and other parts of the state as well. So the classic presentation of measles is fever. It may start relatively low and then begin to rise over the next couple of days. Typically, it peaks over 101 degrees Fahrenheit, sometimes as high as 105. This is a photograph of a kind of classic measles rash from the CDC used with permission. You can see that it's red. It's usually a mix of flat red spots as well as raised red bumps. It usually starts on the forehead near the hairline and then spreads its way down, usually all over the whole body. But depending on how soon after the rash started that you're seeing someone, they might just have it on the top half of their face, or they might have it all over. And then the other classic symptoms are what we call the 3 C's: cough, coryza, which is a stuffy and runny nose, and conjunctivitis, which is red, itchy, uncomfortable, runny eyes. These are two more photographs from the CDC used with permission. You can see that these children both have red, runny eyes. I don't know how well it shows, but, you know, they look a little congested around their noses, a little runny nose. And you can also see they both look pretty miserable, and that's pretty typical. Measles is not a mild illness, despite what you may have heard. It's not something that someone can just play through. Typically, people are very sick and very miserable, particularly unvaccinated people with measles. The symptoms don't all start at the same time. Usually, measles starts with a couple of days of flu-like symptoms. The fever might be a little bit lower then. And then after a couple of days of the cough, the runny nose, the conjunctivitis, and a rising fever, then they'll break out into the rash. And so what you may see is you may have a camper or staff member who comes in one day feeling kind of miserable, cough, runny nose, maybe a lower fever of 99 or 100, and then they may come back in another couple of days now with a very high fever and a full-blown rash. So that's important to keep in mind because people who have measles are contagious and can spread it to other people starting 4 days before their rash even became visible until 4 days after the rash began. So that means that that person who came in with some milder symptoms and came back a day or two later with a rash might have been contagious that first time you saw them before they even had any other symptoms of measles. Measles is one of the most contagious infections. It's airborne. That means it spreads through a virus that spreads in the air. And that virus can live in the air for up to 2 hours after a person has left the space. So that means if you have someone who, say, came into the camp infirmary at 9 o'clock in the morning, maybe at 10 o'clock in the morning, you sent them in an ambulance to an emergency room or urgent care, hopefully having notified the urgent care that they might have measles ahead of time. So let's say they got in that ambulance at 10 a.m. Anyone who comes into that space where they had been until noon, up to 2 hours after they left, could still catch measles from the virus that they've left floating in the air up to 2 hours after they left. Measles is so contagious that up to 90% of people who are not immune to it and who are exposed to either a person sick with measles or were in the same area as them up to 2 hours later will themselves also become infected. The best protection against measles is vaccination. There absolutely, as we'll talk about today, are things that we can do to try to limit spread once a case has happened, but the best thing we can do is prevent cases from even happening in the first place, and that's with vaccination. In the United States, the measles-containing vaccines are in a combination vaccine, most commonly measles, mumps, and rubella, which we call MMR, sometimes with another vaccine, measles, mumps, rubella, and varicella, which can be abbreviated MMRV. Some other countries have other combinations containing measles vaccines, so some might just have a measles vaccine, some might have measles, rubella, MR. So if you have campers and staff coming from other countries, they might have different combinations of measles vaccines. But for all of the measles-containing vaccines, one dose is about 93% effective in preventing the measles, and 2 doses are about 97% effective. Now, it's not 100% effective. It does mean there is a small proportion of people, about 3%, who, despite having had 2 doses, might still come down with the measles if they're directly exposed to it or in the airspace of someone who had measles. But among all the documented and known cases of measles among people who had 2 doses of vaccine before coming down with it, they were much milder than among unvaccinated people. And also, I think critical for public health, they spread measles to much fewer people, so they seem to be less contagious. This is a look at the measles vaccine status of the known cases in New York State outside of New York City as of last week. So the totals today might be a little bit higher than these totals. But I think this really illustrates the degree to which unvaccinated people have driven this current outbreak. You can see that across all age groups, 79% of the measles cases had no vaccine whatsoever. Another 5% had one dose of measles-containing vaccine, 3% had 2 doses, and then there's another 13% or 42 people, most of them adults, who did not know whether they were vaccinated, couldn't find any kind of record or evidence one way or another. It's not uncommon that adults often don't know their vaccine status. A lot of people just don't hang on to those records after they graduate from school. But if we focus in on the people who actually know whether or not they're vaccinated, including people who know they're not vaccinated, then it's even more prominent that among the people with known vaccine status, 91% of measles cases had no vaccine at all. So clearly, the vaccinated, even in the rare cases when vaccinated people have gotten disease, they're much fewer, and it's really being driven by the completely unvaccinated people. Hopefully you've all already seen this flyer, and I think we're going to see it again more than once in this webinar because it's, I think, really one of the critical things that we've distributed. I've cropped it a little bit and zoomed in. This isn't the complete flyer. I tried to zoom in so that the words would be a little bit more visible. I just wanted to take a couple minutes before passing on to my co-presenter on what to do if you think a camper or staff in your camp has measles. So the first thing is to be alert for the symptoms of measles, which I already talked about: fever and one or more of the following: cough, runny nose, red watery eyes, and rash. If you think someone has measles, immediately isolate them, and ideally putting them in a private room with a door that closes, because I talked about the virus spreads through the air, so you want to limit the number of people who are breathing the same air that they are. Keep other people who are not immune to measles out of that same airspace up to 2 hours after they leave, because you don't want them to get exposed to the same air and the virus and become infected with measles. If the camper needs additional medical needs, of course, attend to them. If they're going to need additional medical care in an emergency room or urgent care or other healthcare settings, please call ahead and let them know that you think this person might have measles. If you're calling an ambulance, let the ambulance know you think they might have measles, so that those healthcare providers can take precautions to try to limit the number of other people who might wind up being exposed to this person. If you haven't already, contact the camp health director and determine this person's measles immunity. Are they immune? Do they have any records of vaccine? If so, how many? Or evidence of past disease or lab evidence of immunity. And really critically also, please call your local health department as soon as possible, and they'll give you further guidance on ways to both help this individual as well as try to limit further spread and control, hopefully from preventing a further outbreak. So that's the end of the Measles 101 portion, and I'm just passing along to my co-presenter, Mr. Tim Shea.
Okay, thank you, Betsy. Good morning, still right? Good morning. Thank you. Okay, I just want to give a little bit of an overview of what we're planning to do today regarding camp guidance. First of all, this presentation is based on clinical guidance and best practices to protect against measles in New York State children's camps. The presentation does not address local requirements imposed by counties that may be more restrictive. Currently, Sullivan, Rockland, Orange, and Ulster counties have imposed more stringent standards for measles. These counties now require campers and staff to have proof of immunity or a valid medical exemption in order to attend. We're aware and advised that Greene County may be following suit very shortly. So if you're a camp from Greene County, please pay attention to that. This presentation is largely going to be based on the materials that we've prepared and distributed this fall, for this spring, and we're not going to be, we can't be going into the individual county orders at this time. But we do feel that much of the presentation that we're going to be giving will be useful to camps that are in those counties as well. I do want to acknowledge up front that many of these recommendations go beyond the minimum requirements of the New York State Sanitary Code. We know that. So failure to implement them may not necessarily result in a violation during inspections. However, failure to fully implement them could really impact the operation of the camp during the season should a measles case occur. So we are strongly encourage everybody to closely adhere to these recommendations. There's nothing in public health law or New York State regulation that prevents camp from implementing more stringent standards, so we encourage you to do so. And lastly, I need to emphasize, and you'll hear this several times during the presentation, that you need to work closely with the local health department that has jurisdiction in the county where the camp is located. And this goes for camps that are located in the 4 counties that I previously mentioned, as well as other counties. Some counties have different methods for making sure things are done correctly, and you should be using them as a resource as you go forward. Okay, so guidance to help prevent and identify measles and limit the impact at camp was sent to local health departments this spring for distribution to camps. These went in 2 different mailings. One was in April and the other was early June. In addition to discussing the minimum vaccine recommendations for campers, the guidance addressed collecting and reviewing immunization records, maintaining lists of individuals that are not fully immune, including those with valid medical exemptions, screening and excluding campers and staff for measles symptoms and possible recent exposures, conducting daily health surveillance, and reporting to local health departments. We're going to discuss each of these items in greater detail and highlight the guidance documents that are now available. This just a kind of another note here. This discussion is really limited again to the recent guidance. The presentation is not an exhaustive discussion about camp medical requirements. So if you don't hear something here, it doesn't mean that it still doesn't need to be adhered to. So please keep that in mind as you go through the season and contact your local health department with questions. Most camps are aware that the New York State camp regulations require that they maintain camper immunization records for 9 vaccine preventable diseases, and the requirement stops short of mandating vaccines to attend camp. However, our recommendations this spring has been for all campers and staff to be fully immunized, and that records should be maintained for both campers and staff, and lists should be maintained for individuals that are susceptible because they are not vaccinated. Specific to measles, the department recommends confirming immunity for all camper and staff. Confirming immunity means having written records of 2 doses of MMR, measles, mumps, rubella, having a written record of a laboratory test showing measles immunity, having a laboratory test confirmation of prior measles infection, and birth in the United States prior to 1957. And we're going to talk about each of these just a little bit more, but I want to highlight the last bullet there before moving on, and because I've seen some guidance out there not highlighting the fact that it's got to be a birth in the United States, and we have a lot of international staff, so we want to make sure that we are limiting this measles immunity to just United States residents since '57. New York State camp regulations do not address the type of documentation that is required for proof of immunity, nor do they address religious or medical exemptions. Historically, this has been the camp and local health department discretion to require official documentation for these records. This is not the case in counties that are imposing additional measles orders and may not be the case in other jurisdictions. So be sure to check with your local health department for doing this. For vaccination records, official documentation typically means a written or electronic medical record with the dates of vaccinations from a healthcare provider, or a record from an immunization registry, such as the New York State Immunization Information System, also known as NISIS, or the Citywide Immunization Registry, known as CIR. Camps have legal access to these systems. Your local health department has information and probably has transmitted it to you already for how camps can get access to these to these registries. The New York State Immunization Information System contains campers and younger staff members' records for people that were vaccinated outside of New York City. The Citywide Immunization Registry contains only records for those that were vaccinated in New York City. Self-reported vaccination histories are not considered official documentation. So if there was a measles case that occurs at camps, local health departments and state health departments that are investigating will look at those accordingly. Similarly, written electronic medical records from a laboratory is the only official documentation for laboratory evidence of immunity or laboratory confirmation of past measles infection. For medical exemptions, the department recommends a signed statement from a physician licensed to practice medicine certifying that the immunization is detrimental to the individual. It should also contain sufficient information to identify the issue, specific to the immunization and specific to the length of time for the medical exemption. Consideration should be given to annual updates of that information. To help camp attendees about measles, to help inform camp attendees about measles prevention, an informational flyer was developed and sent to camp operators to encourage them to share with parents and other attendees prior to the start of camp. This flyer is available in English, Spanish, and Yiddish and posted on the department's website. The department's recommendations include that camps maintain a list of individuals that are not fully immunized, including those with valid medical exemptions. To assist with this, a template was prepared and distributed for use. The template is not required for use by camps, but if it's not used, we strongly recommend that the camp have a similar mechanism for identifying those without documented proof of measles immunity. The template helps identify the types of documentation, i.e., whether it's official from a physician or a laboratory, or unofficial, something that was simply submitted by a parent or somebody on their own. The level of immunity, it allows the camp to identify if there's 1 or 2 MMRs, if there's a laboratory confirmation to a test, if there are no vaccinations or tests, and if there is a medical exemption. The template also helps identify individuals that are classified as being in process, which means they have received 1 MMR and are scheduled for a second dose. Second doses are typically administered minimum 28 days after the first MMR, so there's a space to record that on the immunization template. I do want to acknowledge that this template only addresses the measles for this effort here. Other local health departments may be requiring camps to document immunization status for all vaccine preventable diseases. Again, check with the local health department that your camp reports to. Camps are required to screen campers upon arrival to help prevent illness from getting into the camp initially. The department's guidance is to do this for all campers and staff. So in addition to what you're typically doing for campers, we want to make sure there's a process in place for camps. This season, we're highlighting the need to include individuals with measles in the 4 days prior to arrival. The brief description of the symptoms are here. Betsy did a much more thorough job earlier, so we're not going to go through that. We're also need to exclude campers and staff with recent exposures who are not fully immune, including those with medical exemptions or one MMR, and the need to monitor those with 2 MMRs who have not had recent who have had a recent exposure to measles. As we know, there up to 3% of those individuals may still contract measles after exposures. We're strongly encouraging camps to review their screening process to ensure it's effective and to make any necessary improvements. I'm aware of some camps that provide transportation from common pickup locations. Would be advantageous to screen campers before everybody getting on a bus and arriving at camp. So please consider ways that might be done in order not to expose anybody on a bus on the way to camp. We also need to consider how staff are going to be integrated into this screening system. They're not all arriving at the same time, and so the camp really needs to wrap their minds around how they're going to make sure that people that arrive to camp are not already presenting with illness. Consideration should also be given to day camps in which children are coming and going each day. They're not there on the weekends, so are there additional exposures or symptoms that are developing over those time periods that you need to be aware of? This poster was highlighted a little earlier in Betsy's presentation. Just want to call attention to again. We developed a poster to help identify the signs and symptoms of measles. It's available on the department's for download on the department's website. The poster is intended to be put up in the infirmary and can be placed in other locations throughout the camp. If you see at the bottom of the page here, the poster has a place for local health department contact information for easy access and including time periods that are considered off hours, weekends and nights and things of that nature. Camps are required to have procedures for daily health surveillance, and we're again asking camps to ensure that these pertain to both campers and staff, and procedures are adequate and reviewed with staff during staff training processes. Daily health surveillance must include continued surveillance of individuals that had recent exposure to measles. All camps are required to have provisions for isolation and should a measles case be suspected, must immediately isolate individuals and contact the local health department and parent to notify them of the concern. And Betsy already highlighted some of the items that we're looking for. A private room with doors that close. We want to make sure that bathrooms are not shared with individuals that are susceptible, that other individuals that are susceptible are not being allowed access to the rooms. Consideration for campers need to be how are we continuing with supervision, where are they getting meals, who's bringing the meals, and probably much more that camps are more in tune for than I am for providing. But you know, these isolation considerations really need to be well thought out before the season begins, and make sure that that they're available. We are advising that camps track visitors coming and going from camp and collect contact information. Visitors could include intercamp activities, parents visiting days, and many other activities where people are coming onto campus and spending a significant amount of time. So in addition to being a very serious illness, an outbreak of measles will likely severely disrupt the camp activities. And when local health departments are controlling an outbreak, it has broad authority and may impose stringent requirements requirements in order to stop and minimize the spread of disease. If there's a measles case at camp, what should camps be expecting? Well, they should be expecting a team of health department staff to arrive on site. They're going to begin reviewing immunization records and identifying people at risk. A local health department will be focusing on the type of records that are available. Are they official records, or are they something that was unofficial and submitted by a parent? Individuals without official documentation will be considered at risk for the disease, will likely be considered at risk for the disease. The team will look at who was exposed at camp and what outside groups were exposed. Contact information will be requested for everyone for follow-up. And the team will evaluate on-site isolations, the need to exclude people from camp, and or suspend camp activities such as out-of-camp trips. And as you would expect, all this needs to happen immediately. So the better prepared with records, the more quickly the camp will likely be able to get back to its normal operation. In conclusion, I just wanted to summarize some of the materials that are now available from the department on the website. The measles and immunization recommendations for campers and staff is the vaccine preventable disease letter from April. This contained immunization recommendations for campers and staff for all vaccine preventable diseases. It contains links to other websites which specify the minimum schedules. The Measles Reference Guide for Camp Operators provides a summary of the recommendations to help prevent and identify measles and limit the impact. It contains all of the information that was presented in a nice summary that was presented in this presentation today. We have the camper and staff measles immunization record template, which is the tool that I mentioned for maintaining a list of measles immunization status for campers and staff. These templates are not required, so check with your local health department. They may have more stringent requirements, but certainly a similar type of record keeping is going to be needed for this season and will be helpful in the event of an outbreak. And we have the camp measles posters that are expected to be posted in the infirmary and other locations around camp. And just in closing, I need to once again recommend that any camp with questions follow up directly with their local health department that has jurisdiction. They are on the forefront and know your camps and will be able to give you very specific information for what needs to be done in order to get through this season. So thank you very much.
All right, thank you, Tim and Dr. Rauschfang. Just to answer a couple of questions that we got a lot, especially on the location of the materials as well as the recording and slides for this presentation. We will be sending the links to the documents that we referenced here today, as well as a recording of this webinar to everyone who's attended this or registered for the webinar. So that should answer a good amount of those questions, but we did receive some other ones. I'll be asking the questions, and then our panelists here will be answering them. So the first question that came in is, I have a staffer who received 1 MMR and is slated to receive a second dose this week. Can they start work on 7/1?
Yes, absolutely. Once they receive that second MMR, they should be fine to work.
Yeah. Okay. Second question is, how long does the vaccination last? I'm an adult. Am I still immune? How would I find out?
So generally speaking, 2 doses of MMR are considered to have lifelong immunity. The CDC doesn't recommend, if you have that vaccine record, the CDC doesn't recommend doing any blood tests to confirm that it's still working. If you don't have your childhood vaccine record or adult vaccine record, You could talk with your healthcare provider, and your options could either be you could get a shot, or they could do a blood test to check whether you're immune. We don't recommend any further boosters. So if you have 2 doses, there's no recommendation for additional doses, even if you had them decades ago.
Okay. You said that immunized people have less symptoms. What would their symptoms be, and would they still have a rash?
So it's sort of a mixed picture, and I have to say, overall, the fewer cases there are of any particular thing, then, the less certainty that we can say about everyone in that situation. So in our outbreak, we only have 10 cases of measles in people with 2 doses of MMR and 15 in people with 1. I'm not sure the totals in New York City, but there's only been a handful of publications describing measles in vaccinated people. It seems to be pretty variable. I believe all the known cases had a rash, but sometimes it doesn't cover the whole body, or it lasts for a shorter number of days than a typical rash. Some people do have more typical symptoms, but they're less likely to need to go to the hospital or have other complications like pneumonia. Yeah, but fever and rash are key.
Okay. Why 1957? Was there something prior to that? I have a dozen volunteers who were older than that were born before 1957, and just want to have info for them.
So the cutoff of 1957, that's a standard that the CDC uses. It's based on how common measles was in the United States in the mid-century. The first measles vaccine in the U.S. Became available in the 1960s, and generally speaking, in the mid-20th century, measles was very common in the United States, so much so that off the top of my head, I can't remember the exact proportions, but an extremely high proportion of people born before 57 have been found to be immune, either because they know they still have a record that they had measles as a child, or more often because they were tested and found to be immune. If you do have staff who were born before 57 and they're worried about their immunity, they can talk to their doctor. It is always an option for them to get an additional dose, but in general, the CDC does recommend that people born before 57 in the U.S. Are considered immune.
Okay, great. Would handwritten immunization records on a camp form, which is then signed off by the camper's physician, be determined as official documentation?
Tim?
I think we're going to have to defer to local health department that's reviewing those records for that determination.
Are we required to track campers with 1 MMR vaccine separately from campers that have no MMRs?
We're talking about age appropriate for younger children who maybe only are at the age when 1 would be recommended?
Yep, and we did receive a couple questions on that. So, yeah.
Well, from a disease control perspective, if there was a case of measles at your camp, you'd want to know who has 1 and who has none. The response might be a little bit different. As far as routine monitoring, Tim, is there any guidance on that? Or?
So, our recommendation is for 2. So anybody at camp that's eligible for a second dose should be scheduled to receive a second dose. I think what will happen if there is a case of measles at camp, and again, our current requirements don't mandate 2 doses.
Right.
So if there is a case at camp, we're going to be responding to the incident, and that individual would be considered not protected, so susceptible. So
Tim was saying a case, if there, we would potentially treat it even if there was just a suspect, right?
Correct. Yeah.
Great. Is there an expectation that camps have documentation from every camper and staff that they have not been exposed to measles in the last 21 days, or can we inform them that they need to come forward and inform us if they've been exposed?
So we're looking for an active surveillance system. So whether it's a sign-off or if it's just a question that's posed to make sure that there's no known exposures, we can leave that to the camp and to the local health department to figure out how they're going to do that. But we don't want a passive system where somebody's just obligated to tell us if they know. Make sure it's an active system.
Okay. Next question. We run a camp for ages 2 through 6. Children under 4 have all had one MMR, but are not scheduled to have the second until they turn 4. Are they considered incompletely immunized?
Well, so sort of looking around for others who want to join in. You know, what?
Let's talk about how we would handle children in that age group with one dose, which is age appropriate, if we had a suspect case of measles in the camp.
Okay. If there was a suspect case of measles in the camp, then as long as it had been at least 28 days or 4 weeks since their first dose, then they would be considered incompletely immunized and should get a second dose. The minimum amount of time between the 2 doses is 28 days, so if it's been less than that, they can't get it earlier than that. So even though routinely the second dose is recommended at 4 to 6 years of age, it can be given as soon as 28 days after. And in the locations experiencing the outbreak, we are recommending that all of the children get their second dose with at least 28 days after the first, even those who are less than 4 years of age.
Okay, so the next question is, legally, are we able to not accept campers or staffers with medical or religious exemptions?
So neither public health law or state regulations address this, and so you, as camp, would be advised to check with their own legal team to do that.
Okay. What if a camp is open to the public? Should there be a concern for visiting patrons, and what should the camp do in that case?
If there's a suspect case of measles, I think we have to assume maybe?
If there is a suspect case of measles, then you'd need to identify anybody who had been visiting the camp during the time when the person was contagious and might have been exposed to them.
But I will add that we are hoping that camps will be able to track the visitors that are coming and going. Sometimes symptoms aren't always known ahead of time, so as Betsy had said, it could be several days before symptoms appear, so we may need to trace back people that were on site.
Okay, great. We talked about isolating the camper with measles. I assume best practice is to get the camper home with family as soon as possible?
In general, yes. We have to be concerned with how people are being transported. Obviously, public transportation is not something that could be done. And there will likely be a need to temporarily isolate somebody on premises until parents can arrive.
I think if for a camp who is responding to a suspect case among either a camper or a staffer, we would be working closely with the local health department and state health department to provide guidance on issues like that with respect to transportation and isolation procedures.
Great. How long are you a carrier of the virus? Do I have to wait 2 hours before returning home to not infect others?
Well, so if, I guess I'm sort of not sure if this means someone who has measles or someone has recently exposed to measles. If you have measles, then you can spread it to other people up to 4 days after the rash started and starting 4 days before. If you've been recently exposed to someone who has measles, generally speaking, if you're not immune, it takes anywhere from 7 to 21 days for the rash to begin, but that's certainly something you would want to call your local health department, let them know you were exposed to measles, and they would give you advice on trying to keep away from people who are not immune and try to limit further spread. There are also, if you've just very recently been exposed, there are options like getting vaccine within 3 days of the exposure, which might help to prevent your getting measles if you're not immune.
Great. If a child has an allergic reaction to the MMR but has a blood test showing immunity, can they still affect others if exposed?
Well, if they have a blood test showing immunity, then we would consider them immune to measles.
Regardless of the allergic reaction.
Right.
If they show evidence of immunity, they're immune.
Right.
Okay. Is 1 dose of MMR sufficient for an adult?
So routinely, the CDC recommends that most average risk adults born in or after 1957 are okay with 1 dose, but there are certain higher risk adults that we recommend 2 doses for. And in this outbreak, we are recommending that adult camp staff have 2 doses of MMR. Also, people attending college or university, planning international travel, and of course, people in an area that's experiencing an outbreak. At this time, we're recommending 2 doses of MMR.
Do you want to clarify, in our guidance letter, we went into that detail with respect to what we expect for adults, correct?
Right.
And then I would just add that the counties that have issued local orders, at least a few of them have gone into specifics as far as what constitutes immunity or evidence of appropriate vaccination for adults.
All right, great. How can camps receive access to HCS and NICES?
So the department has recently sent out guidance to each local health department. So work with your local health department, and there's forms that need to be completed in order to get access to NICES. It needs to be resubmitted to the local health department, and they'll verify that you are a camp and should have legitimate access, and that gets processed through our central office here. The citywide, I believe, is a little less complicated. There's a link in the guidance that we've sent out, takes you directly to the city system and allows you to register there.
And we're working on expediting the clearance processes for both, so that any camp staff who are looking to access NICES, we think it makes it much easier for you to confirm vaccination status, but we're working to expedite your access.
And we'll get that information on our website as well to assist people with finding the access mechanisms.
Great. Okay, next question is, for campers with delayed start immunizations, is 1 dose sufficient? I'm not familiar with that is, but.
I had mentioned the minimum length of time between doses 1 and 2 is 28 days or 4 weeks. If someone had 1 dose and it's been less than 28 days, then they can't get the 2nd dose until they get to that point. If it's been more than 28 days, then they should have a 2nd dose.
And this is what I was discussing about being in process.
Yeah.
So if somebody shows up, they have the 1 dose and they're waiting the 28 days, your tracking, your template tool that we provided will allow you to identify when that is. It doesn't mean that they won't be considered susceptible should a case of measles occur or a susceptible case of measles occur, but it allows you to continue and attend camp while they're in process.
Okay, great. If a camper is eligible for a 2nd MMR at the time of camp, can the camp nurse give the vaccination?
I'm not familiar with the standards of best practice if there is a blanket waiver for people to administer vaccination. So maybe if you could speak to that. But if there's an order to do that, I believe the camp nurse should be able to administer that vaccination provided they have it.
Right. Yeah, the nurse would have to have an order from a physician or I believe nurse practitioner. But also the local health departments have MMR vaccine in stock, and so you could also speak with them if your camp is not able to administer it yourself.
Great. Next question is, can our camp be shut down if there's a case of measles at our camp?
We would certainly work to do everything we could to prevent that kind of a situation from occurring, but that is one of the important issues that we would be working with an impacted camp to make sure that there is adequate staffing to support the needs of all the children in camp. So that really depends on the circumstances.
Okay, great. The next question is, since measles is airborne, we have heard camps where there is an outbreak could lead to camps in a 2 to 4 mile radius to possibly be closed. Is this accurate?
Yeah, the measles virus usually stays relatively local, so it's not known to spread that far away. I will say if the camps in that radius are regularly interacting with the camp, maybe they had a camp, inter-camp events, you know, it's possible they could have been exposed, but we don't necessarily do a 2 to 4 mile radius.
If we are working to investigate an instance of suspect measles in a children's camp, we'll be looking to see who came into close contact or were in the same airspace as that suspect case for the period when they're potentially infectious. So did they get meals at the same time? Did they have common activities? Were they in the same bunk?
Great. I do want to send out a reminder about the slides, the recording, and the guidance and the flyers are all going to be shared with the registrants of the webinar. We're just receiving a lot of questions on that specifically. So next question is, at what age should the first MMR be administered?
So routinely, it's recommended the first dose at 12 to 15 months. If a dose was given before the first birthday, it needs to be repeated after the first birthday, but it can be given as early as 6 months in locations experiencing an outbreak or children planning international travel, and we are, and the City Health Department as well, recommending a first dose at 6 to 11 months of age for infants in the outbreak areas in Rockland, Orange, Brooklyn, et cetera.
All right, great. We're coming down to the last couple of minutes here, so we'll try and get a couple of more questions in. If you are a parent who has had 2 MMR doses, but you have a baby at home who has not had vaccines yet, can you bring measles home to your child if you have been exposed?
So, 2 doses of MMR is presumed evidence of immunity, but I did say there's about 3% of people with 2 MMR might get measles if they were exposed. So it's not impossible. Certainly, if you think you've been exposed to measles, even if you have 2 MMRs, let your local health department know, and they'll give you guidance.
Great. Just a couple more questions here. I think we can get them in. Should staff have immunizations if they don't already before camp starts?
Everybody should be immunized. That's a simple way to say it.
Or otherwise demonstrate their immunity, right?
Right.
And we identified the 4 different things that could be used to demonstrate immunity in this slide there.
Great. And the one last question we're going to get to here is, can we require campers to bring documentation if coming from an outbreak area, even if our LHD isn't requiring that?
I think that's something you could certainly consider. While you're not currently required to do that, I think our guidance memo to camps certainly suggested that you can go further as a camp to make decisions such as that. And I think that a big point of the webinar was to make sure that all camp operators understand what will happen if you have a suspect case of measles and you are allowing non-immune children and staff to attend. It could, certainly be very disruptive for several days and potentially much more complicated than that. And so we are strongly encouraging camps, even those not subject to county orders, to consider requiring their children attending camp and their staff to be immune.
So I think we're going to wrap this up real quickly. I just wanted to add one point, and that while we are going to share all of these documents that we've prepared, some of the documents may contain confusing information, especially camps that are located within the counties that have implemented more stringent orders. So if there's any point of confusion, please be sure to contact your local health department with questions about that and any other follow-up necessary for this season. So.
Okay, so that's something too. We also have a measles webpage at www.health.ny.gov/measles. We update it daily on weekdays, and so you can find information about the number of cases, about the disease itself, and other resources there.
Great. I want to thank everybody for tuning in today. This webinar. Hopefully everyone found it helpful, and thank you very much.
This concludes today's conference call. Thank you for your participation. You may now disconnect.